Okay, so welcome everybody to our Queen Elizabeth Scholarship presentation and webinar coming to you from the McMaster Health Forum at McMaster University. I want to thank all of you for joining us and our special guest Alexandra Kilian, who is one of our current Queen Elizabeth scholars. We will be going through a quick introduction about the scholarship program, and then we'll be turning it over to Alex, who's going to tell us about her experiences as a Queen Elizabeth scholar while she was in Sydney, Australia. I'm going to ask that we hold questions until the end. If you are online, I'm going to ask that you please use the chat box in order to ask any questions. So here we go. Welcome. As I mentioned, I'm going to give you a quick little summary of the McMaster Health Forum, the Queen Elizabeth Scholarship Program, and then we'll be listening to Alexandra do a presentation on her experiences at Sachs Institute. So the McMaster Health Forum is a leading hub for improving health outcomes through collective problem solving. We strive to harness information, convene stakeholders, prepare action-oriented leaders, and we act as an agent of change by empowering those stakeholders. The Elizabeth Scholarship Program is run by a partnership between the Rideau Hall Foundation, Community Foundations of Canada, Universities Canada, and Canadian universities. The purpose is to activate a dynamic community of young global leaders across the Commonwealth to create lasting impacts both at home and abroad through cross-cultural exchanges encompassing international education, discovery and inquiry, and professional experiences. Here at the Forum, our Queen Elizabeth Scholarship Program is called Strengthening Health Systems, as that is the mandate of the McMaster Health Forum. So our scholars contribute to strengthening health systems and become part of our large and growing network of health system leaders. Who are our current scholars here at the Forum? Here is a list for you. We have currently 3 incoming scholars, 2 outgoing scholars, and a number of outgoing interns, most of whom are now back with us. Rhonda is still currently in Ghana working on her scholarship, and we have just welcomed Bernard, who comes to us from Kenya, and the rest are either have just recently come back from their internships and scholarships or are currently on their way going to their locations. So one of those that I just mentioned is Alexandra Kilian. Alexandra, when she was a Queen Elizabeth Scholar, was an undergraduate student in the Bachelor of Health Sciences program at McMaster University. Prior to her internship, Alexandra explored her interest in global health and health policy through involvement with the McMaster Health Forum as a member of the student leadership team and through a third-year inquiry project under the supervision of Dr. John Lavis, who is the director of the McMaster Health Forum. At University of Toronto, medical student Alexandra Kilian. Here you go, Alex.
Thank you very much, James. So, as James mentioned, through my Queen Elizabeth Scholarship, I had a chance to travel to Sydney, Australia, and pursue a project in Aboriginal health. And while I was in Australia, I noticed that there's a custom called acknowledgement to country. And this is an acknowledgement of the traditional owners of the land on which a certain gathering takes place. And this acknowledgement does not in any way erase any events of the past, but it sets a foundation for a future in which the inhabitants of that land can live in equity and with a shared responsibility for that land. So with this in mind, I'd like to acknowledge that the land on which McMaster operates is the traditional land of the Haudenosaunee and Anishinaabe peoples, and I would like to pay my respects to their elders, past, present, and future. And I'd also like to acknowledge the land on which the traditional owners of the land on which this research was conducted, and that's the Gadigal people of the Eora Nation. And to all nations, thank you for letting me live and learn on your land. So I pursued a research project in Aboriginal health, and this struck me as an important element of strengthening health systems because strengthening health systems is a broad topic. And so when developing a project, it's important to narrow where and how you want to contribute to strengthening health systems. And my goal was to do it through improving health system responsiveness. And by responsiveness, I mean responsiveness to cultures, to religious diversity, and to individual diversity. And also creating values-based health systems. So understanding what the values of diverse populations and trying to incorporate that and embed that in the health systems that then serve these populations. So I pursued so I've pursued 2 research projects, which I'll give a brief overview of, including a general overview of Aboriginal social and emotional well-being, current pathways to well-being, diagnosis-specific pathways, as well as introduce a method of research called co-production and how it fit into the Sachs Institute specifically in their search project, which I'll also describe briefly. and then talk about where do we go from here, what are the next steps in Aboriginal health both in Canada and Australia. So this slide is a gross oversimplification of an extremely complex concept called Aboriginal social and emotional well-being. And does this work? Okay, here. So I'll just point to the different boxes as I refer to them. And I'd like to start by talking about the difference between social and emotional well-being and mental health. And this reflects the cultural difference between Aboriginal people and non-Aboriginal people. Aboriginal people view health as a very holistic concept, and there's no division between mental health and physical health, as well as no division between the health of an individual and the health of a community. And this holistic approach is summed up in the term social and emotional well-being, while mental health reflects a more dichotomized view of health that's present in Western cultures, where there is a separation in between mental health and physical health. And the perceptions of health are really important to consider when we talk about designing treatment and services and more broadly health systems, because they impact how we approach treatment, how we approach diagnosis, and they impact patient trajectories through the health system. And so there's been a plethora of literature that has shown how culture impacts social and emotional well-being or mental health in not only Aboriginal culture versus non-Aboriginal culture, but specific cultures across the world. And with Aboriginal social and emotional well-being, there's not simply the difference in culture that affects the different experience, but there's also the element of history. And it's no secret that over the last 200 years, Aboriginal people in Australia have been withstanding colonizations, and even today are subjected to socio and economic marginalization as well as systemic racism. And both of these experiences leave scars that run deep and present themselves in the experience of social and emotional well-being. And so these elements, particularly the history and the current experience of Aboriginal people, has been cited as one of the causes for the higher prevalence of mental health distress and mental health disorders among Aboriginal people in Australia. So we hear in every area in which we have data, or almost every area in which we have data, there's a higher prevalence, and there's also an increased severity often, with more Aboriginal people presenting to the emergency room with mental illness-related distress or being hospitalized for mental illness-related conditions. And so both current context, historical context, and culture contribute to a very different experience of social and emotional well-being for Aboriginal people in Australia. Yet despite this distinctly different experience, there's a shocking lack of research on this topic. And this is extremely problematic because we then have a poor understanding of social and emotional well-being in Aboriginal populations, and this leads to a lack of adapted pathways as well as treatment modifications. Because if we don't understand what social and emotional well-being is for Aboriginal people, it's really difficult to design anything from medical school curricula to policy, and this impacts clinical care and both policies and services that are delivered. And ultimately, this culminates in the lack of culturally safe services for Aboriginal people in Australia. And again, there's a significant body of literature to report that Aboriginal people do not feel safe in mainstream services. So as a side note, there is Aboriginal controlled community health services in Australia, which I will talk about a bit later in our presentation, but we're talking mostly here about mainstream services. With a lack of culturally services, we see problems such as hindered access, and this is because people don't feel comfortable accessing care in these settings. And when access is hindered, access occurs at a much later point in the disease trajectory, and a much more severe presentation, and this might contribute to poor outcomes. And again, this is just an oversimplification of the concepts, but it shows that there is a cycle, and this is the cycle that I was trying to contribute to breaking through my research. So the research questions that we looked at were what is known about best practices for mental health care delivery in general practice for Aboriginal and Torres Strait Islander young people, and what barriers and facilitators exist in the adoption of evidence-based best practices and recommendations to address mental health challenges in Aboriginal and Torres Strait Islander young people. And it's specifically these barriers and facilitators that act as targets when we want to strengthen the health systems to help improve our response to this situation. That changed formatting, but that's okay. So we conducted a literature review that attempted to find exactly what is known. And so what evidence do we have to help design clinical practice and policy? So we looked at descriptions of care pathways related to mental health, as well as studies showing what is actually happening in current practice. And we hoped to find these two studies applied in an Aboriginal young people population, so 0 to 18 years of age was our inclusion criteria. But we found very quickly that there was not that many studies for Aboriginal young people. So we did look towards the general population to at least understand what is happening generally, and then see potentially where we can make modifications for Aboriginal young people, or whether there have been general pathways modified for Aboriginal young people. And we did approach this through a conceptual mapping process. So we mapped recurrent themes to better understand, and that's kind of where that first flowchart came out of. Those are themes that came up in Aboriginal related literature on social and emotional well-being. And this also applied well to pathways, because mapping pathways based on recurring themes worked out very nicely for us. We also compared Australian guidelines with evidence to uptake in practice, as well as international guidelines and evidence of uptake in practice through using a tabular format. So as I mentioned, there seems to be a higher prevalence of mental health disorders and lower service use among Aboriginal young people. But mental health, or social and emotional well-being, are really, really broad topics. So in addition to looking at this broadly, we did have to narrow at some point. And so we chose to look at the 5 most prevalent conditions based on the literature. And so these are listed here. And we chose to focus on pathways because there is a significant body of evidence that shows that pathways can positively impact patient outcomes by improving efficiency, interprofessional communication, collaboration, and coordination. And improved patient outcomes also is correlated with improved patient satisfaction, and these are all important elements. Moreover, we thought it was a relevant area to consider, particularly because of recent policy changes that have emphasized the role of the general practice setting. So this emphasize the role of the general practitioner in primary care, and specifically in mental health care. So the general practitioner is responsible for recognition, screening, and treatment, and acts as kind of a gatekeeper in the pathway. And with the central kind of coordination, there needs to be service coordination and interprofessional collaboration surrounding the general practitioner. So we wanted to understand, to what extent is this happening and how can we make it better? Our analysis was framed through the Goldberg and Huxley model, and I won't get too into it, but it's basically a framework that talks about how people travel through the mental health care system. It has 5 layers, starting at the community and ending at inpatient specialist mental health care. And there's filters between each level, with fewer and fewer people being treated at each level. And these filters represent patient and physician characteristics, as well as health system characteristics, diagnosis and referral decisions, etc. So we very quickly found that there's very little research on treatment pathways in an Aboriginal population, and any small community interventions are not disseminated beyond that community. There's simply not the tools to disseminate successful pathways or practices. And yet, despite this, and despite the evidence of how effective and how much pathways can improve care, so there's a significant amount of evidence of how pathways can improve care, and as such, there's been calls to action in many peer-reviewed Aboriginal health research papers calling for a more centralized, more coordinated, more formal mental health care pathway. Looking towards the general population, we also see a lot less research than we expected on specific pathways to mental health care. One of the most relevant studies we found had a limited applicability even to the general population, as it was focused on Asian and Arabic-speaking adults, and it showed that their mental health care trajectory took an average period of 6 months before they received primary mental health care, and they saw an average of 3 providers, which is problematic because such a convoluted pathway, particularly in mental health care, leads to complications, increased severity, etc. And this just gives us a glimpse into the Australian healthcare system. Other studies have shown us that the GP is the primary care or gatekeeper in the pathway. And even in that first study that I mentioned, the gatekeeper was seen at some point, or the general practitioner was seen at some point in that pathway for more than 60% of that patients. So the general practitioner does play a really, really important role. The general practitioner can either treat, once recognition occurs, can either treat in their general practice or refer to a specialist. And the data from the Australian general practice setting shows us that pediatricians are the most common specialists to which children with mental health problems are referred, and psychiatrists are the least common specialists to which children with mental health disorders are referred. Again, this was in the general population, so its applicability to an Aboriginal population is not fully well understood at this point, but it gives us a little bit of a glimpse and a little bit of an understanding of what actually happens in practice in Australia. We divided this pathway into 3 steps: help seeking, practitioner recognition, and referral, diagnosis, and treatment. And at each stage, at each division between these steps, similar to in the Goldberg and Huxley models, there's enablers and barriers. So enablers to help seeking included a recognition of need, and this could occur by either the patient themselves or a caregiver or community member. And this was often confounded by or related to severity, level of distress, and community awareness. Accessibility was also really, really important. This includes consideration of location, transport options, affordability, and availability. Awareness of services and resources also played a big role in whether or not people access care, because whether they know where to access and they know that help is available can inform that decision. Finally, having networks that support help seeking, that encourage and actually potentially help that young person seek help, was also a positive predictor of help seeking. And all of these factors mentioned here were shown in at least one Aboriginal population study. With regards to the second barriers, or the second step, the main barrier was GP recognition. So the general practitioners were simply not recognizing mental health distress in their practice. And this was kind of surprising to us. So we looked a little bit more into it. And I'm not going to take too long on this flowchart because it is quite complex. However, I guess what I wanted to emphasize by putting this in here was how complex health systems are. Now we're zeroing into a very small part of a bigger pathway, and there's so many factors that play a role. So when we're designing system solutions, we need to have an understanding of these factors, and we need to understand the weight that they play in different contexts, etc. What we found when we looked into GP recognition was that general practitioners were feeling kind of professional stress based on the increasing elderly population, increased amounts of patients with chronic disease, and just increased breadth of conditions that general practitioners have to manage in their practice. And this led to often a limited consultation time being offered to children who seemingly have perhaps less complex presentations. However, this limited consultation time could affect care, because we found that a lot of patients were presenting with not actually psychosocial complaints, but with physical or somatic complaints that were the manifestations of a mental illness. As well, this limited consultation time started during physician training. So registrars, which are similar to residents in Canada, registrars in Australia were getting limited exposure to pediatric mental health conditions during their training, and this made them perhaps less confident and less skillful in recognizing this in practice because they simply hadn't been exposed to it during their training. So ultimately, under-recognition hinders assessment, obviously hinders diagnosis, and leads to under-treatment of mental health disorders in pediatric populations. So that gave us a general overview of what's happening in the general sector of mental health care and primary care. However, we looked into the specific populations, and we looked into whether or not Australian guidelines exist. We ended up summarizing these guidelines, comparing them with descriptive studies in the general and the Aboriginal populations. And we looked at specifically whether guidelines had any kind of modifications for Aboriginal young people, because we know that Aboriginal young people, or there's significant amount of evidence to suggest that Aboriginal young people have different needs, particularly in mental health care or social and emotional well-being. So very interestingly, we found that the Australian guidelines for depression and generalized anxiety disorder, there was not much research in the Aboriginal populations about those conditions. The Australian guidelines for depression did have some modifications for treatment of Aboriginal young people, but this mostly included the recommendation to practice in a culturally competent fashion without giving the tools to practitioners of how to actually achieve cultural competence in their practice. And there was no modifications at all for anxiety for Aboriginal people, which is also a big concern, and also no descriptive studies in Aboriginal populations. Conduct disorder is a very niche disorder, and so we weren't necessarily surprised that there were no Australian guidelines and no modification for young people, because it's very, very specific and it affects a small number of the population, but the people that are affected, the families and the children, they do struggle significantly. So it is an important consideration. The Western Australian Aboriginal Child Health Survey was the only descriptive study, or included a component that we considered a descriptive study of conduct disorder, and this just emphasized that Aboriginal children are significantly more at risk of clinically significant conduct problems. The ones that I want to focus on are attention deficit hyperactivity disorder and post-traumatic stress disorder, as there was a significant amount of evidence and some modification in guidelines. So with regards to ADHD, the Western Australian Aboriginal Child Health Survey found that 15% of Aboriginal children were at risk of clinically significant hyperactivity as compared to only 7% of non-Aboriginal children. And the Australian guidelines recommend psychotherapy as well as stimulant use for treatment, yet the stimulant use among Aboriginal people or young children was markedly lower than it was among non-Aboriginal people, despite the higher prevalence. And so the authors in this paper presented several potential explanations. They included culture as a coping mechanisms that may make the symptoms less destructive in that community, or that ADHD symptoms are perceived as normal behavior, as well as potentially negative attitudes towards medication by caregivers or lack of access to medication. Another study looked at and interviewed caregivers of children with ADHD in Aboriginal populations. And these caregivers did recognize that ADHD behaviors were undesirable. They did cause problems to both the child and the communities in which that child rotated in. So not only their classmates, but their families and their friends. But past negative experiences with medications made parents or caregivers hesitant to pursue this route with their children. And they really emphasized the need for one-on-one consideration per case, that a one-size-fits-all approach will not work. And that goes back to the idea that the health system needs to be responsive to the needs of an individual. And I know that's a bigger task than it's easier to say than execute, but it's really, really important. Another thing that we found or that Lowenal reported, was that Aboriginal parents of children with ADHD reported a lack of knowledge about ADHD treatment options and facilities. And this is really, really problematic, as if parents of children who have sought help for ADHD don't know about treatment options, etc., this provides an indication of perhaps what can be happening in the general community with a lack of awareness of what services are available and how to seek help. We also chose to focus on PTSD, as though there's no studies at all in an Aboriginal young population, there is some evidence or a significant amount of evidence about the trauma in Aboriginal adult population. So one of the most shocking studies was conducted by Nadu and al, and they found that in a sample size of 221 in Western Australia, the lifetime exposure to traumatic events was 97.3%. And out of this 97.3%, the participants meeting the diagnostic criteria for PTSD was over 50%. And given these high numbers, these shockingly high numbers, and the knowledge that trauma is transgenerational, so it doesn't only impact the generation at which it is experienced, but it has impact on subsequent generations, and that has been shown in Aboriginal people, we definitely thought this was an important one to include in our research. The Australian guidelines of PTSD acknowledge the complexity of trauma in Aboriginal populations and included an entire chapter dedicated to modifications of the treatment of PTSD in this population. The authors, when trying to write this chapter, conducted a systematic review, but this systematic review identified 0 studies that helped them produce evidence-based guidelines. So as a result, they convened an expert panel to help develop recommendations for treatment. And this is much more than any of the other guidelines have given in terms of modifications for Aboriginal people, and so this definitely needs to be commended. However, on the hierarchy of evidence, expert opinion is one of the lower tiers of strength of evidence, and particularly when something is so important like social emotional well-being, PTSD, we really want to base policies and treatment interventions on evidence-based, peer-reviewed studies. So that's kind of the next we might want to take in this direction. So bringing back this flowchart, there's two kind of boxes highlighted in yellow that I'd like to focus on for the remainder or the latter half of my presentation. Firstly is the lack of adapted pathways, and even though there are a few adapted pathways, there have been evidence of things that have worked in specific communities that may be adopted across the country to help improve the cultural responsiveness of the treatment we're providing to Aboriginal young people. So I'll summarize those on the next slide, and then I want to talk about how to address this problem of lack of research. It's clearly a big problem. We don't have evidence-based guidelines for any of the top 5 most prevalent mental health conditions. So how do we get research that is applicable, and how do we work with Aboriginal communities to ensure that that comes back to the community in a way that's beneficial to them? So there's many things that have been recommended in the literature, and some recurring themes were cultural competence through cultural consultations with elders, with community members, etc., to help develop culturally appropriate assessment tools and culturally appropriate treatment protocols. There has also been suggestions for cultural supervision, as well as cultural training specifically for both providers, as well as community members that might be engaged in treatment or working at a facility in some way. As well as mentioned, pathways with coordination and interprofessional collaboration are an important way of improving the efficiency through which people travel through the healthcare system. And so this has also been recommended, specifically a centrally coordinated suicide response pathway in Central Australia for Aboriginal young people has had some success in the community, and this could be replicated across other communities as well, and not only limited to suicidal ideation or depression. And lastly, next, a lot of studies have shown or emphasize the importance of family and the kinship circles in Aboriginal communities to treatment. Once again, social and emotional well-being is not an independent thing. It's deeply related to the community. And so involving community members and involving family members, given the consent of the patient and the willingness of community or family members, is a really important way. So health promotion, giving the tools and the space to actually be engaged in an individual's treatment is a potential step that services can take to help improve the cultural responsiveness and appropriateness of health systems and treatment pathways. Lastly, pathways need to be flexible. They do have the potential to improve trajectories greatly, but if they're too rigid and they can't really be applied in many contexts, if they're only applicable to a specific context, the uptake will be low. And we need to consider that age affects how people travel through and where people access service. Where people access service affects their treatment trajectories and their subsequent service use. Rural versus urban communities also differ greatly in what resources are available, etc. So pathways need to be able to take into account these differences in resources and patient populations, etc., and really provide the service providers with the tools to implement elements of the pathway, but also recognize the constraints that exist in different environments. So the next thing I wanted to touch on was the importance of research and trying to break the cycle that we see. And research is important because it can help inform policy and practice, but also because it can help design tools and services that can translate policy into practice. However, the relationship between Aboriginal people and academic researchers has been a little bit strained based on past experiences where research was done on Aboriginal people rather than with Aboriginal people. And research outputs were rarely returned to the community if at all, or in a way that was useful to the community. So recognizing this past experience and the legacy of that experience and trying to work with communities to overcome it is a really important thing. So one thing that has been suggested is co-production, and co-production is a process through which, formally defined as a process through which inputs used to produce a good or a service are contributed by individuals who are not in the same organization. So in this case, a good or service is research. And co-production places everyone involved on the same level, and everyone has continual space for input, and everyone's input is equally valued. So, for example, if we were doing research with an Aboriginal community, we'd have the community members involved, we'd have academic researchers involved, and we'd have service providers involved who can share their experience, their very real lived experience and knowledge that can help design a research project that meets the needs of the community and that runs successfully. So there are several elements of co-production, but again, it goes back to that idea of equality. So community members are active agents. There's an equal relationship between all people involved, and the outputs are returned to the community. The research participation by the community members is supported, so the organization or the academic researchers obviously or might have more training in academic research, but providing that training to the community members so that they can be active contributing members should they wish is an important thing. And participation is continuous. So at all levels, community members are involved, community members are given a voice, and that voice is as valuable as anyone else sitting at the table. So the study of environment on Aboriginal resilience and child health was the project under which my projects fit at the Sachs Institute. And this project was designed as a long-term investigation of causes and trajectories of illness in an urban Aboriginal population. And this is because there's a significant disparity in life expectancy between Aboriginal and non-Aboriginal people, approximately 17 years for males and 10 years for females. So trying to understand where that life expectancy diverges, where it and why it diverges so significantly, and identifying targets for interventions was the goal of search. As quoted from the methods, search is built on strong community partnerships, is under Aboriginal leadership, and addresses community priorities. So once again, all those tenets of co-production are right there. There are currently four participating Aboriginal controlled community health services, which I mentioned are safe spaces in which Aboriginal people can receive primary care. They are owned and run by Aboriginal people. They employ predominantly Aboriginal people, and they are really responsive to the needs of Aboriginal people. The search steering group is the study investigators, representative of the Aboriginal Controlled Community Health Services, as well as the Aboriginal Health and Medical Research Council, which is the body that oversees all Aboriginal health research in New South Wales. So at the beginning, many years ago, there was a discussion or multiple discussions to identify community priorities, which were identified as being the health of children, as well as holistic research considering social determinants of health. And based on these discussions, the design emerged, which was a cohort study that took into account clinical measures, general questionnaires of both young people and their caregivers about wellness, about eating habits, etc. And the study was integrated within the care of the Aboriginal people seeking care at the Aboriginal Controlled Community Health Services. So with given patient consent, blood pressure results or blood lipid levels are communicated to their general practitioner so that their general practitioner can respond appropriately. So this research does not just contribute, again, back to the Sachs Institute alone, it actually impacts directly the health of the individuals that are involved. So the driving purpose of the research is to stimulate action to improve health for urban Aboriginal children and their families. And that's kind of the motto or the mission statement of search. And, oh, that's formatting. But essentially, this model is constantly evolving. So as we move, we're currently in phase 2 at search. And as we use the results of phase 1, there's the ability to evolve priorities. There's ability to understand what new things need to be done, what worked and what didn't. And again, when anything changes and when any kind of decisions are made, everyone is at the table. And that is the main strength of search, or there's many strengths, but as a predominant strength of search. The research results translate to the communities in many ways. So new and enhanced programs and services, as well as increased resources and information for communities. So a really good example of how search translated to actually impact on the community is that phase 1 identified high levels of otitis media, which is a middle ear infection in Aboriginal children. And this is much higher than the average population. And based on this result, search was able to advocate for increased funding from the New South Wales Ministry of Health to provide screening for all Aboriginal children in Aboriginal controlled community health services. And this allowed, the screening process allowed for children at risk of or with developing otitis media to be identified and referred to a specialist for early intervention. And middle ear infections have impact on speech and language development, on achievement in school, on social interactions, etc. So this one change had a huge impact on the trajectories and social and emotional well-being of young children. So this model, or the search project, attributes some of its success to several principles. And this includes strong government. So again, those guiding principles, those community values and needs, they're constantly being reflected upon as the study evolves, as the study design changes to incorporate new data, etc. But those guiding principles are at the forefront of those decisions. And there's, again, that explicit focus on using data to improve health. So publications are not just published and left in a journal. Publications are used as a means of advocacy, as a means of actually driving change in communities. And that change is very, very tangible. And there's Aboriginal leadership, community knowledge, and research capacity being built. So for example, Aboriginal research officers are the ones that are actually collecting the data, conducting the interviews, etc. And they receive training, they participate in research conferences, etc. So this really builds capacity. But these Aboriginal research officers are one of the reasons search is so successful. With any cohort study, you run the risk of low retention, particularly in multiple phases. But Aboriginal research officers understand how their community works. They are part of that community, and they know when is a good time to perhaps follow up with a participant and when might not be a good time. They know how to communicate what search is to people in a way that is meaningful to them, so they do actively participate in the study and see its value to the broader community. As well, the data is communicated back to Aboriginal communities in a way that is valuable to them, and so this is done through a process called knowledge brokering, in which an Aboriginal person acts as a liaison between, for example, the Sax Institute and Aboriginal communities. And so that data comes back to the community in a way that's usable to them, and that is meaningful to them. And again, knowledge brokers bring back feedback from Aboriginal communities to the Sax Institute to change certain things, etc. And again, the process is constantly evolving. So that brings me to the end of my presentation. I just have a couple of thank yous and acknowledgements to make. None of this would have been possible without the incredible staff at the Sax Institute and the McMaster Health Forum, who were supportive throughout my entire internship, and I am so, so grateful to them. And as well, Dr. John Lavis, who is my supervisor here at the forum, and Dr. Anna Williamson at the Sax Institute have provided incredible mentorship and support, and so I'm very, very thankful as well. Thank you as well to you guys for coming out and listening and for tuning in. Thank you.
Thank you, Alex. Don't go away. So we'll open up. I have a last slide. There we go. If you're online, then feel free to type your questions into the chat box, and I will read them out. If you're in the room, feel free to ask a question. So while people are thinking about their questions, Alex, I'll ask a question. So from a health systems perspective, what can you take from the health system in Australia in regards to Aboriginal mental health, and how does it translate now back here in Canada?
Thanks. So one of the most, I guess, the things that struck me the most in Aboriginal healthcare in Australia was the fact that the element of Aboriginal ownership, which I think is starting to happen in Canada, but Aboriginal ownership is a really important part of health service delivery. And Aboriginal people often express that they only feel comfortable, or they feel more comfortable seeking help in an Aboriginal-owned space. And creating more of those spaces in Canada can help perhaps address some of the problems we see in our health system. And so that's one of the main lessons that I'm looking into, how we can do that and how we can achieve that. And I'm hoping to go into some of the Aboriginal health services in Toronto and the Hamilton area shortly to understand how the system works there and how some of my learning in Australia can apply there.
Thank you very much. Are there any questions for Alex? Anybody in the room or anybody online who has any questions regarding Alex's presentation and her time at the Sachs Institute? Yeah. So you can just say your question and I will repeat it for those. So the question in the room was about what barriers you came across in terms of
So actually, the last week at the Sachs Institute, I was at a research meeting that specifically had all the Aboriginal research officers from the different communities come in, as well as the study participants and Aboriginal researchers that are not working on this search study, but from other institutions as well. And one of the things we talked about was challenges in Aboriginal research, and particularly retention. So, for example, Aboriginal research officers were talking about how problems in the community sometimes prioritize coming in for the study appointment. So that really affects retention within search. But once again, it's that community knowledge from the Aboriginal research officers that can help overcome that, at least to some extent. But at the end of the day, we need to be respectful that things come up and the study might not always be the priority of the community, particularly if there's a crisis in a family or in a community. And that crisis affects people much broader than that nuclear family. That crisis is felt across the community. So when there is a crisis, that really does impact the study. However, that crisis is so much more important, and responding to that crisis, that it can't really even necessarily be classified as a barrier. I don't know whether I'm communicating what I want, but yeah. Okay, thank you.
So the question in the room is the experiences of working at Sachs and the types of conferences and people that you related with.
So day to day, my experience was quite varied, actually. So some days I was just from 9 to 5 working on my literature review. There's a nice kitchen where I'd have my lunch and interact with other people from the Sachs Institute, etc., and working on different projects, which was always a highlight. So that would be one kind of day. Other days, I would come to the Sachs Institute in the morning and then meet up with one of the Aboriginal research officers, and we'd drive out to one of the Aboriginal communities. So that would be a day where I would observe and help the data collection go smoothly. I didn't actually conduct any of the data collection, but it was just allowing me to observe how the health services actually work, the Aboriginal controlled health services, as well as just help with preparing the different tools needed to conduct the measurements and ensuring data inputs and etc. So that was another kind of day. As well, we had conferences and meetings. So the University of Sydney has certain presentations that our supervisors encouraged us to go to. So I went to one that looked at how we can learn from past health policy experiences, such as alcohol and smoking regulation, and translate them to current problems such as obesity. So that was really interesting. So beyond Aboriginal health at this point completely, I went to a conference called the Emerging Health Policy Research Conference, where I actually presented some of my 3HO3 work with Dr. Levis, but there was a lot of people from the Sachs Institute who were presenting their research, so that gave me even a better understanding of what's actually happening at the Sachs Institute. So I had the chance to go to a couple conferences, a couple meetings. My supervisor, Dr. Anna Williamson, was great. She met with me every 2 weeks to kind of check in where I was and give me feedback. And so I'd kind of be preparing for those meetings in between the conferences and other experiences. But I thought it was very diverse, and she was always open if I wanted to do anything, always open to my suggestions. So it really was what I wanted to get out of it. And so I think I made the most of it. I have no regrets coming back. And so, yeah.
So we have a question online. What is the one key advice you would give other students thinking of doing the same kind of work you did?
That's an interesting question. All right, so the one piece of advice I think, when you're doing community-based research, I think it's important to remind yourself that this research isn't for you, and it's contributing to an overall greater purpose, I would say, as cheesy as that sounds. But sometimes being flexible and open to what is needed of you is really important, because you will learn through that experience no matter what, and you will gain from that experience. But it's also important for you to give as a researcher, and that was something that I reminded myself a lot at the Sachs Institute.
Another question online, wondering if you had any thoughts about intersectionality within the Australian Aboriginal population and how that might have affected your work.
Also, another very interesting question. So I did actually consider intersectionality quite clear, reflectively in my work. For example, just simply the intersection between the Aboriginal population and young Aboriginal people. So young Aboriginal people in Australia generally have a different experience of mental health than non-Aboriginal adult Australians. So then, and they're more vulnerable to decreased health seeking, etc. And so that vulnerability intersects with their identity as an Aboriginal person, and their Aboriginality, as well as their status as a young person transitioning perhaps from childhood to adolescence, may affect their experience of social and emotional well-being. As well, I didn't do a lot of research into it, but I do really consider the intersectionality of gender in everything that I do, and that's something that I'm really interested in further exploring. It didn't come up a lot in my research. There is certain differences between men and women, girls and boys, when we're talking about young people, but I can't comment as in depth as I would like about that.
So the question in the room is whether or not the perception of the people on whom the research was being done impacted the work, and if so, how did the work, and if so, how would you accommodate for that?
So just to clarify, is the question the perception of Aboriginal people by researchers? Is that, or? Oh, the perception of Aboriginal people about mental health. So that would be something probably to ask an Aboriginal research officer, because they're involved in the data collection, more involved than I was, because the data collection is only conducted by an Aboriginal person. And that's one of the reasons I think that the Aboriginal identity of the research officer was so important, because it can be easier to share about those experiences with someone who comes from the same culture as you, where you have the same perceptions about mental health and you understand this holistic view, versus if someone was talking to me, that might be a lot more difficult, as I come from a culture that doesn't necessarily see things the same way. So I think that the study tried to overcome that challenge by ensuring that data is only collected by Aboriginal people who share the same perceptions.
So another question online. What was one thing that surprised you during your internship?
All right, there were a lot of things that surprised me, I think, during my internship, but the thing that I took away the most was just the incredible resilience and dedication of the communities. And these communities are dealing with so many problems, but at the end of it, they're constantly working towards bettering themselves as individuals and as communities. And that was represented in, just for example, the Aboriginal research officers, who I just have so much respect for, because they would go out and do everything that they can to help support the Aboriginal people in coming to this study, and support them in a way outside of the mandate of the study. But that is representative of the Aboriginal culture in a whole, and it's representative of that close kinship. And that was something that I just admired from afar. And yeah, I remember the last day that I was saying bye to some of the people. That was like the thing that I took away the most, I think.
Thank you. Any other questions from anyone online or in the room for Alex? So the question in the room is basically, since Alex has done work in the Australian healthcare system, what lessons has she learned that we may be able to apply here in the Canadian healthcare system?
So I think I touched on that partially with James's question with the Aboriginal owned health services, or I think something that can be transferred to Canada. From Canada, things that can potentially be transferred or that differ from Australia. So, for example, the pediatrician in Australia is a secondary healthcare provider. It's a specialist healthcare provider, and you need a referral to see a pediatrician. But that may complicate the pathway for young people. So if they have to first see their GP and then their pediatrician and then get referred to mental health care, for example, that's one more person in the pathway to see, versus here, a lot of children do have a pediatrician from age 0 to 18 and can get directly treated there without having that extra kind of person in there. But I think the thing that's important to remember with health systems, and that I was reminded of throughout my internship, is that every system has pros and cons. And so the pro of of having a pediatrician as a not necessarily a secondary specialist provider in Canada is that the trajectories might be less convoluted, but then that affects funding, that affects availability of pediatricians, etc. So in Australia, I think the thinking is to manage less severe conditions in general practice and more severe pediatric conditions by pediatricians. So again, I think every system has pros and cons, but that's something that can be kind of considered or transferred from Canada to Australia.
Wonderful, thank you. And our time is drawing to a close, so if anybody has any more questions, this would be the time to squeeze it in. No? All right. Looking online, it doesn't look like you have some congratulations and things like that, but I don't see any more questions. So at this point then, I will thank Alex for taking the time to doing this webinar and the presentation. It sounds like she did a lot of work in Sydney. She told us before the webinar that she didn't really have a lot of time to do much else while she was there, and I think we can see why after watching that presentation. So thank you very much, Alex. For those of you online and watching this later on in YouTube, please note the links that we have on the screen. The first one there is a link to the Forum Scholarship page, which will give you all the information about our scholarship program. The second link is a sub-page within that scholarship section about the QE Scholar Insights, where we list all of the webinars and presentations that we're going to be doing this term from all of our scholars who have recently come back from their internships and scholarships. So please check that out and tune in for future presentations and webinars by our Queen Elizabeth Scholars. And the last link is to our Queen Elizabeth Scholars blog page. So all of our scholars, in addition to doing a presentation and webinar, will also be writing a blog about the lessons they learned while they were away at their specific placements. So look forward to Alex's blog there coming soon, and all of the future scholar blogs will also be posted on that website. So thank you, Alex, and thank you for all of you for joining us.